maxillofacial surgeon from GDC Bombay, QDA from NIAR. I have finished my fellow and diplomate both of the ICOI and the ISOI. And from day one, my whole interest was always implantology. Okay, so I'm a consultant maxillofacial surgeon at Implantology. I am also a professor of practice at the DY Party Bombay. Now, what is a professor of practice is different from your regular departmental practices. I am an honorary professor in which we are trying to bridge the gap for the students between what is academic work and what is clinical work. In what we do in the clinic versus what you do in academics. So we have 5 of us and we take 5 lectures every year on differences. So I speak there on extraction, wisdom teeth, sometimes implants, sinus lifts, all that. So they understand that interns, first year, second year PTs, what they are in for, when they get out of the college. So that's my job and my other people. So that's very interesting, and that's something that I really enjoy doing. Secondly, many years back in GDC, when I was there as a lecturer, we had the opportunity to do a course, and whatever proceeds from that course we made, we went ahead and bought an implant system. And you have to understand that it was a different time that time, 98, 99. In the whole country, there were 8 or 9 implantologists, you can call them. And I had the privilege of placing the first implant ever in UDC Bombay. Okay, we caught some patient who agreed to pay for the implant, and we did a couple of implants, and then we continued the department. In fact, the biggest discussion at that time was what to name the department, because it's government, right? So government has to have a Marathi name, and there was no word coined for the word implant, right? So they had to think of all kinds of things. So finally they decided on something called a Dantaropan. That was the word, and it was a big thing because they made a board and the health secretary came to inaugurate it. But the thing was, because of that, it started our journey. Actually, someone like Dr. Shavil, who ran the Frail 2 system, because there were only 2 systems in India at that time. So he actually held our hand and helped us to place the first implant. And it's been a journey, frankly. It's not easy. Implant dentistry has so many aspects. The best aspects of surgery, the best aspects of fixed prosthodontics, both of which are our interest. So we learned. And over a period, it's gone through so many changes. Because when we started, there were no CTs at all. To understand, it was only IOPAs, and sometimes on models we had to do something called as ridge mapping to figure out how much bone is there under the tissue. So all those things, you mark it on the model, make a cross section and mark it. So all that changed the way we learned. Okay, so we made a lot of mistakes, lot of mistakes. But over a period, it got better and better. Literature started coming in. You have to understand, that time there was no internet. Okay, we are from that era. There was no internet. The iPhone was still 8 to 10 years away. So if you wanted to read an article, you had to have college membership to a library. It was very different. So, and no one knew anything, right? Everyone teaching you also was clueless. So it took us a long time, and the first many years were quite traumatic in terms of the learning curve. But having said that, it's been a good journey. 28 years since I last placed my first implant. It's been good. My family, I don't know why they're looking at me, they're from Mars, but that's my family. So in '99, there was a case which came to my clinic. I just opened my clinic, and a patient came with a cricket ball injury. Okay, he was playing cricket and he broke his central incisor. The root was still there, and you guys know Dr. Ali Munkiwala. So he's my classmate. So we both started the department together. So he was the prosthodontist, and he said, what, Darshan, there is this thing called immediate implant that we can do. We don't need to wait. We just remove the tooth and place the implant at the same time. So of course we did the extraction and I placed the implant. Now I'm seeing it is so horrible, but I keep this slide every single lecture to remind me that with no literature, we always make mistakes. With not being backed by prosthetics, we are always thinking surgically. So the implant place was a 14 mm implant. It was too wide for that space. Okay, but we managed it prosthetically. At that time, even the labs were struggling because there were only 2 labs doing the implant work, and we didn't have anything like castable abutments. So we had to basically fashion it out of something, and I don't even know what they did, but they did something like this. At that point, which was good, and we finished the case. So I've never met that patient again. If I meet him, I'll apologize to him for this, but it went off okay. My point in putting this slide up is always to understand that the mistakes you make shape the way you turn up. right? You learn how to do it better and better. And this case was the benchmark. And in fact, it's always there in this case whenever I'm talking implants, because you learn over a period. So when we are talking immediate implants, okay, most lectures will be based on the anterior segment, the aesthetic zone. But today what I'm going to talk on is the posteriors. I hope you're okay with it, because the thing is that it is the most neglected, but at the same time, it is also the most important. Because in the posterior segment, the biggest advantage is you don't need to temporize. Most importantly, most complications in extraction and immediate implants occur when you have put some kind of a temporary. And when you try and do a temporary on an implant which is just placed, it's again a second compromise. But you go posteriorly, patient has been without those teeth or with broken teeth, he's extremely okay to wait for 2 more months or 3 more months, whatever it is. So today we're going to concentrate on that and we'll discuss. If there are any questions on anterior, of course I will be there to answer them. Right? But like I said, we're going to start with the basics. You can't do a course on immediate implants without extractions. Right? When I was in NIAR, we learned a lot of extraction. We did extraction in bulk. Okay, to appear for my final second exam, we had a quota of 800 extractions. Okay, without that, they didn't let you appear for the prelims. So you have to understand that that bulk of work that we did, horrible work, but we did it, was important to shape the way we are. But over the last 10, 15 years, all the things that we learned at that point, we have to unlearn. Because a lot of things that work for extraction don't work for when you want to place the implant at the same time. The bone is the last consideration in that kind of extraction, right? You're just concentrating on removing the tooth. Your instruments are rudimentary. You're working with all kinds of horrible instruments. And if you see, even today, if you go to one of the government colleges, the instruments are horrible. They use those big, elevators. And now when I see it, I don't know how I remove tooth if I have to do it with that, right? Because it's changed. Like I said, what has to change is your mindset. You have to make that change to understand how to move ahead. And if you refine your technique, things become easier, right? So we know what an extraction is, basically the removal of the tooth, right? And you have to understand that every single patient who comes to you, either for an extraction or an implant, is very fearful. Okay, that is something you have to circumvent. Because patients say, I'm not scared, but every single patient is scared. And that's one of my most common dialogue to the patient, that you may not be scared, but every single patient is scared. It's just the degree which is different. Right? No one likes it. No one likes something being done in the mouth. No one likes alien. No one likes injections. Right? So what I have learned is, whenever it is possible and it's not an emergency, the scheduling of the case is the most important. Okay? If you're a morning person, do schedule every single procedure surgical in the morning. There are 2 advantages to that. Patient is fresh. He doesn't have the whole day to think about it. Secondly, you are fresh, most importantly. And the third thing that is there, which is for me very important, is that any complication which occurs during the day. The calls at 1 o'clock in the morning have stopped, right? Which is important, right? You're not doing this 24/7. You need to have a life beyond dentistry. So scheduling it in the morning is, I feel, an important thing, because everything is fresh. Everything is freshly autoclaved, everything, staff is fresh, everything works. Now, when you assess a patient for anything, you will go through all these steps, right? You will go through your general evaluation, medical history, you will go through drugs affecting the extractions. You look at something called as ASA classification, and then radiographic evaluation. Surgical. Number 2 is someone who has some kind of disease, but it is mild, managed by the patient himself. No problem. You can ask the patient to check their sugar, check their BP, and you're good to go. Regular with medication. Number 3 is moderate systemic injury. So moderate is the time when you would be speaking to the physician. Okay, you will speak to the physician, take his permission, you will ask them for permission, any changes, stoppage of medication, that's what you do. Number 4 is the kind of cases you refer to us at hospitals that you don't want to do in the clinic. It's dangerous. Dangerous to the patient because their systemic disease is severe. You don't want to be in a position to be treating a patient where the chances of complication are higher and the chance of any kind of morbidity is even higher, right? So that's the kind of patient you would refer to a specialist in a hospital or someone's clinic. Number 5 and 6, they are not for us. Those are patients which require urgent surgery for some other systemic illness. And number 6 is the patient who is already dead and is an organ donor. Okay? So 1, 2, and 3 are the patients you treat in your clinic. Correct? Now when you go to all the diseases that they have, see, some of them are workable, some of them are not. But if you see, there are certain situations which each of these can create problems. Like if you see hematologic disease, for example, patients who are on blood thinners also, and patients who have some kind of blood dyscrasia also. So these are the patients you will be very careful about because the risk of bleeding is high. Then patients who are smokers, for our implants or for our extraction, smoking more than 10 cigarettes a day is a big risk, right? Because that creates a kind of vasoconstriction in that area which delays healing. And patients don't understand that because their first thing is that, "Arey, itna stress hai, ek cigarette pega to kya hoga?" It's like that. But the protocol for implants ideally is that they have to cease smoking 2 weeks before and they have to restart if they want to after 6 to 8 weeks. How many smokers you know can do that? 0, right? It's very, very rare. Then, patients with cardiovascular disease. There are various levels of cardiovascular disease. There are patients who have undergone a angioplasty procedure recently. So generally in those patients, for the first 1 year, you try and avoid whatever you can, right? Because they are on medications that you cannot stop or modify. And if you do it, it is a high risk. Coming to the medication which influence, it is a good practice to ask the patient what medicines they are taking. Then ask the patient relative what medicines they are taking. And I'll tell you a case. I had a patient who came to me and it was a mobile 8, wisdom tooth extraction, old lady. It took me 5 minutes to extract it, local anesthesia, tooth out, everything fine. That wound just didn't heal. I kept asking them, why is it not healing? My thought was that I moved the tooth, I curated the socket, everything. Medications were fine, she was a mild hypertensive, she was taking medicines, there was no bleeding at the point. So then, on the second or third visit, I asked her, are you taking any other medicines? So she said, no, I don't take any medicines. Then, she said, हाँ, मेरे neighbor कुछ दवाई लेती है, उसके पड़ोसी के लिए उसने मेरे को भी Patients remember the medicine they take every day, but they don't remember the medicine they took once a month or once in 6 months, the injection that they took. Now you have your denosumab and even your bisphosphonates, it can create a huge problem for you if you don't stop it or if you're not aware of it. So these are medicines. The pertinent question to ask is, are you taking any medicines even once a year? Right? So that is something that you guys need to remember, besides the daily medicines. Diabetes, anticoagulants is another thing. See, there are 2 things. One is called an antiplatelet and one is called an anticoagulant. Now when the patient undergo the angioplasty procedure, they give them both. That's why the 1 year period is always tough, because they are on clopidogrel and ecosprin. Once, if I am doing a procedure, and most of my patients, because I am in Leelavati hospital, most of my patients are medically compromised. You would say 80% of my patients have at least 3 diseases, minimum, not 1 or 2. So they are highly medically compromised. It's an older age group that I treat. So most often if you tell the cardiologist that I don't mind if you stop the clopidogrel but continue with the ecosprin, they will give you permission because they are happy with that. And ecosprin 75 milligrams does not create a problem. Most cases of bleeding I've had in my life have been from granulation tissue, which people neglect to remove. Right? They always forget that part. It's never been systemic unless the patient is highly medically compromised. High level cirrhosis. Patient is hypertensive. Also, a lot of times you can diagnose patients of hypertension while working on them. When you're working on a patient who is mildly hypertensive, midway through the procedure he starts bleeding. And he bleeds from all the sides, not one. That is a classic indication that there is reactionary hemorrhage. And the reactionary hemorrhage comes from the fluctuation of the BP. And people think that, my BP is okay now, I can stop the medicines. And they stop it on their own. That is something that you will be very careful about. What BP medication does is keeps the BP at par. That is what you want. You don't want fluctuation. Fluctuations are dangerous. So that is something you need to advise the patient and work around, right? So far so good. Okay, so when the patient comes to you, you have to watch him from the point he walks in, right? You know, if there are any deficit, any difference in the gait, all those stuff. And when the patient comes, you examine the patient from outside inside, face, you know, changes in features, anything in the lip, is their oral opening good enough? How are the cheeks? How is the tongue? And then last you go to the teeth, right? That's how you go from out to in. That's what we call an external exam. Intraoral, of course, you see the oral opening. You check that area of concern what you're working on. You see the lips, mucobuccal fold. You check the consistency of the saliva because you're making prosthesis, right? The saliva has to be good and adequate. You have to check each quadrant for health, every single quadrant. Because you're not treating a single tooth, you're treating the whole mouth. Every procedure you do, even on one side, affects the other side. If you're doing an implant here and you're planning an immediate loading, you have to see whether there are teeth on the other side. Because if you're going to start eating immediately from that, you're in trouble, right? So that matters. When you're doing an extraction, what you have to decide is the decision making on how you're going to do it. For that, what matters is the location of the tooth. Is it an maxillary or a mandibular tooth? Is it an anterior or posterior tooth? What are the roots that you're likely to encounter in that? And what are the restrictions around it? What do I mean by restrictions? There are three things that we have to be careful about, right? The nasal cavity, the maxillary sinus, and the nerve. Three things. Anterior segment, no problem. As long as you don't do anything really stupid. Anterior segment, you're absolutely fine. Even maxillary anterior segment, as long as you don't go very deep, you're okay. Posterior, of course, is a concern because of the sinus, and when it's pneumatized, it becomes a bigger concern. But overall, these are your anatomic restrictions. One of the other things you have to decide, and this is even for regular extractions or extractions in which you're going to place implants immediately, is why is the tooth being extracted? What is the indication for an extraction? Is there a pulpal disease? Is the tooth completely broken down? Is it fractured? Is the endo gone for hell? Is that the reason you're extracting it? Is it periodontally compromised? So all these factors influence not only what you're going to do, but whether you will place an implant or not immediately, right? Like infection. There are two types of infection, acute and chronic. Acute infection, you will see an X-ray, you will not see anything periapically. Sometimes the tooth is tender, the patient has pain, but the tooth has no periapical per se, because that is at that point progressing to a periapical abscess, which will go into a cellulitis, which will go into an abscess. Okay? If you can see a black ball around it, that's a chronic abscess. That's a chronic lesion at the tip. Those are often better cases to do immediately, because that is now circumscribed. So you have to make that distinction between acute and chronic, and that is a very important thing in the decision making. In the extraction when you're doing, you have to see the tooth, because all these factors influence how you're going to extract it, right? What is the width of the tooth, the CG? How many roots do you likely to encounter? What is the likely length of the roots? Because the length of the roots also matters, right? What is the size of the trunk? The size of the trunk is this space, you know, this area, from the CJ to the percussion area, because that will affect how you're going to proceed with the extraction. What is the degree of divergence of the roots? Is there any dilaceration that you can see? What is the access, the mouth opening good enough? Is the tooth in the anterior segment or posterior? Is there any mobility at all? Okay? Is the crown there or not? Can I grip it with a forceps or I can't? That matters. Okay, that's how your decision is going to be made. What are the position of the adjacent teeth? Do I have any adjacent tooth? Because often when you're elevating, the presence of an adjacent tooth is an advantage. If there's no tooth next to it, it's often difficult, right? What is the condition of the bone? Is it soft? Is it hard? What is the age of the patient? The patient is 16 years old and you're doing extraction for orthodontia. It's often easier in a 12-year-old than an 18-year-old. The same tooth, right? Because the bone is far more flexible at 12, 13, 14. At 16, 18, it is rock hard. It's very difficult to elevate. You have to think about imaging. Now, what is imaging is your IOPA, your OPG, and now CBCT. Three things, right? Now, IOPA is a very, very valuable tool. Even if I take a CBCT for the patient, I will always do to a higher case of that root. Because it gives you things that often a CBCD is so big and there's so much information that you tend to miss it. Plus when you're seeing cross sections, something like this you can miss, a dilaceration, right? So there will be dilacerations, there will be long roots, there will be caries which you can't see, there will be length of root which is long, you will see an impacted mesioderm sometimes which you can't see otherwise. You will see an impacted tooth inside, the root on top looks very small and innocuous, but you need to see whether there is something blocking its path. You have two which have more roots than normal. You expect 2 roots, sometimes there are 3 accessory roots. There are teeth with hypersymmetrosis, right? There are teeth which are endodontically treated, which on the surface look as though they are not. An endodontically treated tooth is often the most difficult tooth to extract, and everyone knows this. Why? Because why is it brittle? Because now our endodontic techniques have progressed to the level that they use 6-degree taper, and you remove 6 degrees from inside the canal, it becomes very narrow, right? The shell that is available, the cementum, is very, very dented and cemented. Again, hyposymmetrosis, again, fractured teeth. All these you can't pick up that easily on a CBCT unless you're looking very intently. And don't wait for the CBCT report to come. You have to understand that CBCT report is done by someone who is not always looking at it in detail, right? They are looking at it broadly and maybe somewhere remotely. Sometimes the center send it to some other OMDR person who is looking at it superficially. So you can't depend on that. You have to learn how to see it. And OPG is something that I use for screening. If I want, I will send the patient for an OPG just to understand what it is. But now the value of an OPG is going down because we most often ask for a CBCT, right? So I just wanted to show you this case. Okay, now this is a case which a patient came with a swelling to me. Okay, and these are patients what we call file patients. Because see, being like a tertiary hospital where I work, we get a lot of patients which have been everywhere, and then they land up with you. They've gone to dentist A, B, C, and then finally they land up with you. So this patient first went to a dentist. The dentist saw her. He took a X-ray. He said that you have an impacted BCG. The swelling that you have is because of that. So he started on antibiotics. It worked for some time. 3 months later, it came again. 2 months later, it came again this time. So she was concerned, so she went to a physician or a medical doctor. He saw it and said, no, this is not anything to do with your teeth. I think you have tuberculosis. So he sent her to a surgeon. The surgeon did a FNAC of her lymph nodes. That came back negative. So then she went to someone else. He said that you have a salivary gland issue. And you need to be treated for that. So for that they did antibiotics again. It settled down. And it came back again a few days later. So, the decision that she had to make was whether to remove the submandibular gland or not. And that's what she came to me for, actually. I want to remove my submandibular gland, and someone has suggested that an oral maxillofacial surgeon may be a better place to do it. So I said, okay, let me see it. We sent her for a CBCT. Now, looking at this X-ray, it looks that the 8 is impacted, difficult impaction. 7 is there, 6 has a filling in it. We sent her for a CBCT, okay? Now, this is what we saw. Can you see that? The 6 in which a composite filling was done, okay, a very deep composite filling, has an accessory root which is created an infection which is perforating the lingual cortex. Okay, the lingual cortex is perforated, and the person who referred it to me is a very, very talented endodontist, but he said that she suffered enough. So we extracted the tooth. When we extracted the tooth, it was difficult because there was one more root which was poking that way. So we had to remove that root separately. And the swelling completely went away. So you understand what is the value of a CBCT? It gives you pictures which you can't otherwise diagnose. I'm saying this because often patients are reluctant to spend that 2,500, 3,000 rupees for a CBCT, but it is absolutely worth it. And especially in cases where you're doing treatment of the whole mouth or something or the other, even restorative, it is worth it. So you can pick up things like a periapical infection, you can pick up cracks, fractures, sometimes you can pick up external resorption, you can pick up some periodontal infections. All these things, or even a cyst in the sinus, all these things are something that a CBCT can do. And coming from an era when we didn't have this tool, I think you guys are very lucky. It is very, very accessible. Every corner there is a CBCT machine. There is no area in Bombay where you can't get, or anywhere in India for that matter. CBCT is a must. Okay, so now you have done the examination, you have done the diagnosis, you have done the planning. Now you have to formulate an extraction plan. What is When you go from plan A to B, you are in little difficulty. But when you go D onwards, you are in trouble, right? Because that means that whatever you have planned to do has gone to hell. Okay, I was going to upload the elevator, I was going to do this, I was going to do that. That's all gone to hell. Now you start panicking, and at that point you take a drill and you start drilling everything around it. Okay. The key is that if you have a plan beforehand, how to treat that particular tooth, which goes all the way till D, E, F. Most often you will not go for it. You have to plan it before. So formulating the extraction plan is an important thing. You need to have certain instruments which are non-negotiable. You need to have something called the perotome, in your clinic. Perotome is a very, very thin instrument which is used to incise the periodontal ligament. You need to have forceps and elevators, of course. You need something called the curved periosteal elevator. This is my instrument of choice, for raising the flap. Someone was asking me about raising the flap. That is the instrument I use to raise the flap. Okay, I don't use your regular periosteal elevator because this has far better access. It looks like a Boone's probe that we use, but it's much sharper. It is more tapered and it has a better ergonomic design to hold. Surgical handpiece, most importantly luxators. Okay, now we have moved away from elevators completely and we use only luxators for every single procedure. Sutures and needles. This is what you need if you're doing any extraction. Without this, you should not start. Right? All your instruments that you have, you lay them out. You send them out. Okay? Midway through the procedure, you don't want to be running for a forceps. Okay? Or you're telling your assistant, oh, bayonet leke aaya, he's looking at you, you've never heard of what a bayonet is before. Right? It happens. Every clinic it happens, I've seen it. Every single clinic, the assistant never knows what you're talking about. Right? So you have to know. You tell, okay, premolar forceps, and he's giving you a molar cow horn. He's giving you this forceps, he's giving you a maxillary forceps. So that is something which happens in every clinic. I've seen it. I've worked for 30 years as a consultant in various clinics. I know everything that goes on. Right? You have to have all your instruments laid out beforehand. At the most, you will return them back to the drawer. And now you have individual packaging to seal instruments so that once you autoclave them, you can only open them when you need. And whatever is used, you repack and autoclave. Right? There is no excuse. I'm assuming everyone now uses a B-class autoclave. If you all don't, please start because they are not very expensive anymore. Because sterilization in our country is a joke. Right? It is an absolute joke. The assistant will wear a pair of gloves in the morning, and till evening he'll use the same gloves and he'll handle everything thinking that he's wearing gloves so the instruments are sterile. It's a fact. Correct or wrong? Correct me if I'm wrong. Right? So we have to be very, very careful about sterilization because infection from our instruments is unpardonable. You cannot do that. Right? So individually pack your instruments, individually lay them out, select what you need initially, and then move ahead. Always buy the best instrument for surgery that you can afford. Why I say this is because there are instances that our markets are flooded by cheap level instruments, dumped instruments. You go to a conference, there are these stalls which are like everything just lying and they're just throwing instruments at you for like 200, 500 rupees. Those are not the instruments which will serve you in a crisis. Okay? There are times when I just require to extract a wisdom tooth after doing everything. I'm holding the forceps and I press it and the beaks open up like this. It happens. I'm telling you, I've done this for 30 years. I know everything that can go wrong. And I've seen 100 clinics in Bombay. All these things happen because the instruments are cheap to begin with. Why I talk about good instruments, I'm a second generation dentist, luckily. So my father in 1962 bought forceps from a German dentist who was leaving and he gave his instrument second hand to my father in 1962. Those instruments still are spotless, even today. Why? Because they are great quality. They are quality that you cannot find. But at the same time, now in India, you get fantastic, good level instruments. So invest in, instead of buying a whole kit of extraction for about 6,000, spend that 16,000 or 18,000 for the full set. Good instrument. So, or upgrade it slowly. No one is telling you to buy it on the first day, but you buy the forceps that you use daily. You buy more of them, buy better ones. There are companies now, Korean instruments which are excellent. You get really good ones. Invest in them. And always use instruments the way they are meant to be used. I know I'm boring down with these basics, but these are the things that change everything. Like for example, so many clinics I go still use a wax spatula as a periosteal elevator. Many clinics. You tell them, give me a periosteal elevator, they give you a wax spatula. Because they couldn't spend that 500 rupees extra to buy something which does the job so much easier. It's basically what it was born for, that instrument, right? It was born to reflect a mucoperiosteal flap, but you're using something which is not. Also, retraction. You need one or two good retractors, that's it. Okay, you can do all the surgery that you want with it. You don't need fancy instruments. But no one has that. They'll use a periosteal elevator to retract, they'll use sometimes a mirror back. Those things don't work. It makes your job more difficult. The same job that you would do in 10 minutes takes you an hour because your instruments were not right. So buy good quality instruments, invest in those, and they will change your life. Okay? Always use gauze. Now this is core basics, but you'll be surprised how many people still use cotton in their clinics. Okay? They use cotton, they squeeze it, and then one of the biggest complications are shards of cotton lying in the socket. Most commonly. You get excellent gauze now, and very, very cheap. You get these, woven gauze which look like this, which don't leave strands. You don't need to buy that big sheet and cut it up. You get these packets and packets of gauze which are very, very reasonable. And see, you guys don't do surgery all the time. You probably will do it once a week, twice a week, thrice a week. For that, if you use 2 pieces of good gauze, it's a worthwhile thing. So that makes your job so much easier. Always wet the gauze and squeeze it completely. One of the things that people don't do is squeeze the saline out of it, because that leaves it wet. Anything which is wet will not absorb. Right? So these are things that you need to remember. Another thing before this slide is, how many of you use magnification while working? Only 3? Because you are young, is it? Your eyesight are all good. Is that why? You'll need to start using magnification for everything. Okay, now this is a basic standard of care. Okay, when you're using magnification, your vision changes. If you're using magnification with illumination, it's even better, right? So I don't have a picture of that, but I have a listing of what I use. I use a headlight with 2 lights, which give a concentrated light which is shadowless. It makes your job so much easier with magnification. So something like that changes your life. If you're using loops for procedures, the loops come with a light. So invest in that. Okay. How many of you use topical anesthetic before using injection? All of you. How do you all apply it? And then?
Keep it for 1 minute and then give the anesthesia.
Very good. Sorry? Rub it. You don't know this? You don't have that thing. You don't have the ability to rub it, but it's a good idea. So if you use a spray, the spray has a little bit of shock value, right? When you shock it, you inject, then you have to inject immediately. Often you don't have to wait. If you use a gel, you dry the area completely, you use a dollop. A dollop is this much, okay, not a sliver. Use a dollop on that space, allow it to be in contact with the gingiva for 1 minute. Okay, it has to be in contact with mucosa for 1 minute before you inject. Okay, and always inject in the mucobuccal fold. So that is the area which is least painful to the patient. Okay, always inject with the bevel towards the bone. Always inject slowly, very slowly, and always inject above the periosteum for a painless experience. Once you do that, the pain goes away. Then if you want to deposit a little bit of solution below the periosteum, after 2-3 minutes you can do that. Then the patient will never have pain. Right? Why I am saying this is because I am very impatient. So I am very bad with this topical anesthetic. But I have seen the value of it over years. Patients are much happier. In fact, they ask for it now. So using a good topical always helps. Then, do you all use cartridges? Do you all use wires? Everyone? Some people use wires. But it's a good idea to shift to a cartridge because the cartridge solution is often sterile. And it's a single use and throw. Rather than a wire which is always contaminated because the needle is always lying inside it. Right? You're drawing from it again and again. It's contaminated solution. Plus the companies which make wires often are not regulated, a lot of them. Some of them are very good, some of them are not. So often, if you buy LA solution, it's not regulated as well. It has a lot of preservatives which create problems. But a good wire, an international quality wire, it takes one thing out of the equation, one complication out of the equation. So that's worth it. What kind of local do you give? For any tooth in the mouth, more often than not, it is an infiltration. Except when you're extracting the posterior segment, the molars and up to the 5, I give a block. Okay? Then, when I'm doing a sinus lift surgery, is the only time when I give a PSA. Okay? Otherwise, always infiltration. Palatal infiltration is a must. All those who think you don't need it, you do. Right? You need to give a palatal infiltration to augment it. Again, we spoke about the art of infiltration. Very, very, very slow. Okay? Into the mucobuccal fold, level towards the bone and above the periosteum. When patients came to me initially, when I was just out of MTS, when I used to extract mobile teeth, the patients often get pain in spite of giving a lot of injection. Then I started thinking that I'm losing these patients because they get pain when I was extracting the tooth in spite of depositing so much local anesthetic. Why was that? Is there is a reason why teeth are mobile. They are mobile because of
Perio problems.
and when there is perio problems, there is always a lesion of some kind or bad tissue, cannulation tissue around it. So in spite of giving your infiltration buccally, lingually, the patient still has pain when you move the tooth. So it is always a good idea to inject into this tissue, around the tooth. So they may feel that injection initially because they are injecting into a closed space, but while extracting, they will be fine. And what does the patient remember? The extraction. They don't remember the local at all. Because they're so relieved to get over with it, they're fine if they have a little bit of pain. But if you give them pain while you're doing the extraction, that lingers with them. So this is just a little bit of practice management to remember, right? Make the extraction painless. Okay, so when I started out and I was consulting, I used to always have this problem that my inferior alveolar nerve block never used to work well. There were patients in which they complained and they didn't get the symptoms. Oh, this is not becoming numb. The tongue is not becoming numb. There was no profoundness of anesthesia. That is because the technique we were taught, and that is the technique which is there in our textbooks, in Monheim and this and that, is about entering the needle into the pterygomandibular space and then flooding that area with local anesthetic solution with the hope that it will go posteriorly and hit the mandibular foramen and the entry of the inferior alveolar nerve. Correct? So what is our regular technique is that we bisect the premolars on the opposite side, go inside, go medial to the pterygomandibular raphe and inject, right, when you hit the bone. So there is a technique which I have basically found called the anterior radial technique, which works very well. Okay. Now what this is based on is anthropological measurements of human mandibles. When they say that the average width of the ramus of the mandible is around 34 millimeters. Most of them. The mandibular foramen lies bang in the middle of that. So that is at 17 millimeters, right? So our point is to get the needle and the local anesthetic solution as close to that as possible. So when you're in that space and you're close to it, your local anesthetic will always work. Right? So if you see this, the ramus flares outwards. The arch is always inward, but then the ramus flares slightly outwards. Right? So when you bisect the premolars and you go, you're hitting this area here. Right? If you hit this area here, there is a big difference between where your foramen is and where you have deposited the solution. So what we do is we check the width, and this is obviously on a model, but it's around 34 millimeters, 35 millimeters. You take your needle and you put an endodontic stopper on it at 17 or 17.5 millimeters, right? Then you go in the same way, you bisect the premolars on the opposite side, you go in, you hit it, okay? You understand that you are in the pterygomandibular space by the fact that you don't have tissue, right? It's like an empty space. You understand that. Now all of us know that. But at the same time, you are this far away from the foramen, right? So the solution that you deposit here will filter through, but not always. So the idea of the anterior radial technique is to straighten the needle at this point while you're inside and go inside up to your endodontic stopper and deposit the solution, and you're just next to the foramen. Right? So that is a foolproof method to see that your block acts. 99.9% of the time it will act. It will not act in very few. Okay, when the anatomy is different, or sometimes you hit it and you're into muscle and you don't realize what to do, then you have to come out and go back inside till you find the right spot. Your entry has to be without any kind of hindrance. That's when you know that you're in the space. If not, you're in the muscle. And that is what is giving you trismus. Injecting into your medial pterygoid muscle. That's what gives you trismus. Okay. Are we good so far? Okay. Now, we are talking about extraction for immediate implants. So, in this, what are our goals? First is the buccal plate or any bone around it has to be maintained. Okay, we have to save the bone. The socket form that is there has to be maintained. You cannot change the socket form. It has to be as conical as it was when you started. You have to use minimal trauma. And the socket which is there has to be prepared for implants. Right? These are the 4 goals of our extraction technique. The 5-wall concept is about having all the 5 walls intact. That's the buccal, lingual, mesial, distal, and the apical. Right? Now, the instruments that we use have different roles. If you use a periotome, its role is to sever the PDL. Okay, we are trying to sever the PDL to loosen the tooth. A luxator works on 2 principles. That is your wedge action, and because of the tip that it has, it works on the inclined plane principle. You remember your technique in your textbooks, your anatomy textbooks, your oral surgery textbooks, principles of elevation. Okay, simple lever, you had your inclined plane, your wedge. So the luxator works on those 2 principles. While the elevator that you use works on a lever principle. Good so far? Forceps, they just deliver the tooth. Now there's another thing called as physics forceps. Have you heard of that? I have never been able to remove a single tooth with that. And anyway, if you are doing immediate implants, it is counterproductive because for us, preserving the interradicular bone is critical. In a physics forceps, if you're trying to dislodge the tooth like that, you're always going to be in a disadvantage with the interradicular bone. So forget about this. Okay, we'll stick to these 4, right? So what are the types of extraction? Again, simple extraction and sectional extractions. Okay, what is a simple extraction? It is in the one which we normally do, right? You will reflect the gums with a Moon's probe. Sometimes you will go deeper so that you can see the tooth. You will use an elevator to loosen the tooth. You will use a forceps which you're gripping below the CJ as far as possible, and then you're going to use all kinds of forces, buccal, lingual. You're going to try and rotate it and then remove it. So that is what we are doing in a simple extraction. Okay? Now this is a little counterproductive to what we are doing. We are trying to preserve the bone, and one of the goals of our atraumatic extraction was to preserve the crestal bone and maintain the root form, the socket form. That you lose here. Because the moment you start dilating the socket, you already lost your bundle bone, which is the top part of the bone. Right? So this is something that you do when you're doing a regular extraction, okay, for an orthodontic patient. When you're doing an extraction for implants, and this same technique you can use for all extractions, you have to go to something called as sectional extractions. Now what forceps do, they don't pull the tooth out. What they do is that they sever the PDL, make it loose, and then you extract the tooth, right? And the tooth has to pop out with the forceps. A small video of extraction. You move it buccally, you will move it lingually. Slightly here you are severing the PDL around it, what you call the circumferential or the superficial PDL, which is on top. Then you give a little bit of apical pressure to dislodge it from its apical PDL. And then the PDL which is in the middle, the circumferential PDL, you start moving it around, and that's what you do. And at this point, the tooth, there is some release of enzymes and acids into the space, and they make the PDL disintegrate. And that's what allows you to lift the tooth out. Right? What we are going to concentrate on is something called as sectional extractions. This is what I'm going to teach you all today. Right? This is the main course. We are done with the entrance, with the starters. Okay? Sectional extraction can be used for any extraction. Any extraction that you do, you can do with a sectional method. What is a sectional extraction? Is basically breaking a tooth into its constituent parts. Now, why we struggle with this? Because we don't use the right instrumentation, right? We can't do it on our own. And you can use it for the toughest of cases. It works beautifully. Okay? When we were at college, we had this instrument. This instrument was something called as a shearing forceps. How many of you have heard of a shearing forceps? No? So the job of this instrument was to cut the tooth, but it used to grip the bone. And you press it so much that the bone cracks first and then you crack the tooth. So that is now completely out. We can't use this at all. This is a very old technique. Why do we do sectional extractions? Because every root has a path of removal. It has a path of extraction or a path of removal. When you break a tooth into its constituent parts, you allow yourself that path of removal. That path becomes available to you. Okay? You minimize the risk of root or crown fracture. Because you cut it up, you can see it better. Okay? You don't need to use force. And with this technique, you protect adjacent teeth and structures. Correct? So sectional extractions is what you need to do. For that, you need a handpiece like this. Now, this is a surgical handpiece. Okay, it used to not be available anymore everywhere, but now it's available everywhere. It's a 45-degree surgical handpiece which doesn't allow the air, it works on your air rotor. The air doesn't get propelled in, it goes backwards. But what it does, it rotates the burr. Right? So there is a water jet which comes. So you can use sterile water in your water bottle. But it doesn't allow for air emphysema because the air doesn't go front, it goes at the back. So that's a huge advantage. And you have the power and the speed of your air rotor to use. So all you have to do is replace the handpiece. Earlier it used to be worth 50,000 rupees, then it became 20,000, now you get for 5,000 rupees. Okay, if you buy a basic brand. Because you don't use it that often, you will use it very minimally. And handpiece will last you for months and years. Right? So what are the steps in a sectional extraction? First things first is your coronectomy, that is removal of the crown. You cut off the crown. Why you cut off the crown? To expose the trunk of the tooth. Okay? On the trunk of the tooth available, you split it into at the furcation level into the constituent roots. Okay? With the burr. You cut it with the burr to expose till the bone. Okay? Then using your luxators, you separate them into whatever, 2 roots, 3 roots, whatever you do. Then you luxate individual roots and then you deliver the sound. Okay? In all this, very rarely you will use a forceps. Very rarely. Means I must be using it in 1 or 2 out of 100 cases. Right? It's mainly about luxation. So, in a maxillary premolar with 2 roots, this is the point of sectioning. In a maxillary molar with 3 roots, this is the point. First is the palatal, you separate the palatal from the buccal and then you cut the buccal into 2. In a mandible, you cut it straight. This is buccolingual. Okay? So this we know because we know anatomy, right? We know how the roots are placed. Good so far? Okay. So a situation like this. Now this is the root we have to remove. Okay, now something like this we will always get scared of because it's a difficult extraction. There's nothing to grip. Okay? We will just cut it. First we cut it like this, separate the buccal from the lingual. Then we cut it again like this. Right? All this we do without raising a flap. Okay, you don't raise the flap. You don't even have to wait for the air to act because technically you are working on the tooth. Right? So you cut it like this. Now once we have it into its constituent parts, then we have to remove one root, remove the second root, remove the third root. Now how do we remove them? Is with luxation. Again, this is the mandible. We split it buccolingually into 2. Okay? When you cut it, you have to be careful that you are not going too deep. Now, in the previous, did you all see this burr? Okay? This is an excellent burr from this company called Comet. It's a PET burr. You all know what a PET technique is? Partial extraction technique. Partial extraction is a technique used in immediate implants as well. So, it's an extremely sharp burr. It's a carbide burr which works beautifully. Sadly, it is not available, but there are others which are now available similar to that. But it cuts like a hot knife through butter. So you have to be very careful about when you use it. Because you can cut the tooth, you can cut the adjacent tooth, you can cut the bone, you can cut everything with it. Right? But with this, our job has become much easier. And air rotor plus this burr means my split is done within 30 seconds. Right?
What brand is available here?
So this one is Comet. I don't know the name of the, but there are many. Not now, but it will come. It was available 2-3 years back, and now it will get available. So they're still doing the registration. But you get other companies. What you need is a long shank surgical burr, which is carbide. You get many burrs. SS White also has it. Okay. When the tooth is a single rooted tooth, like an anterior tooth, most often you can extract it singly. You don't need to do any splitting, right? Because it's a front tooth, single rooted tooth. But there are times at which you need to split it because you can't remove it. It just doesn't budge. In which case, there is this excellent article by this guy called Darshan, in which he outlined how to do it. So basically, you identify the canal space and you extend a cut to and fro without breaking it. Why do you not break it? Why don't you run the burr all the way to the end? Because the risk of cutting the buccal plate. Right? You cut it this much, then you put your luxator inside and you crack it into two. And then you remove them separately. Remove this part and remove that part. So you go, you cut it all the way, then you split it into two and you remove them individually. Is that clear?
But you can cut mesodistally as well.
So mesodistally you will only cut when you are doing it for PET. Most often you cut it longitudinally, buccolingually. Like if you are doing a PET case and you have this situation, that's when you cut it like this, in a T form. Because this part you still want to maintain inside. Right? What you are going to remove is only these two. Remove one piece, remove the second piece and you're done. Okay? Now this is all about the cuts. Okay, what is the difference between a luxator and an elevator? Is the angle at which you apply it in the instrument. A luxator is always used along the long axis of the tooth. An elevator is used at 90 degrees to the long axis of the tooth. This is what we normally do, right? This is what we have been trained to do in all our colleges. This is what you learn to do. Okay? Now the thing with this is you have to be very careful because the chance of slippage is high. You have to basically protect it with your hands, both sides, and then work. So these are the instruments I use. Now Directa is one of the companies, but they are the original makers of luxator. Right? Now the thing with them is they are extremely expensive but very, very good. So I buy one set every year, which costs me 6,000 rupees each instrument, but that's good because then I use it very roughly throughout the year. Right? But now there are much cheaper alternatives which have improved in quality, much, much better. Okay, so these are the two luxators I use, just these two. You don't need to buy the whole set. You need the 2S and the 3S. 2S is a 2 mm wide and the 3S is a 3 mm wide. If you see this, this is a 2S, it's green in color. The 3S is grey in color and it is wider. Why you need these two? And I always buy the straight. There are very fancy angles which you get like this, like this, like this. I'm not comfortable with them because I still want to work along the long axis of the tooth, right? So why do you buy two of them? Because both have different roles. The 2S has a role of going just below. It is basically wedging into place and creating a gap between your tooth and the bone. It is going into the periodontal ligament and it is separating it and cutting the superficial periodontal ligament fibers. Okay, it's cutting them with your pressing. The moment you press it, because it is slightly inclined, it opens up the gap between the tooth and the thing. Then the 3S is what you use to loosen the tooth. Okay, not the 2S. 2S is too thin. If you use the 2S to loosen the tooth, it will break. If you're not familiar with its use. So you have to go with the thicker one while you're trying to actually move the tooth, and this has only a job of wedging it. It just wedges, and then you put the 3S and you slightly turn it around. Okay, that's what loosens the tooth. So this is a video this is the instrument I was talking about, the curved periosteal elevator. It looks like a moon store, but it's a periosteal elevator. What I'm showing you here is for immediate extractions and implants, how much tissue reflection you need. That's it. I just release the pepper on either side. I don't expose the bone at all. Why you don't expose the bone is because you're cutting off the blood supply. Once you cut off the blood supply, your healing of your implants are compromised. Right? And you don't need to. Because you're working from a occlusal space. You're not working buccally at all. Right? Clear so far? Okay. This is another valuable thing that I use. I don't use a blade for reflecting the gum. I use it often buccally to wedge it between the tooth and the bone. Using a very thin blade like this, it's thinner than your luxator, right? And your buccal plate is extremely thin. So sometimes just creating that little bit of space by putting the blade in between the tooth and the bone just gives you that little bit of space. Okay, it gives you a space in which the chances of you fracturing the buccal plate when you're extracting the tooth are less. So this is an advantage. Okay, so this is not recommended if you don't know how to do it, but what you do is just press it in and create a space between the tooth and the bone. And this is how you use the luxator. You basically use the 2S up to this level, just below the CJ, just below the center of gravity of the tooth. And you sever the superficial fibers, and as you sever it, you go deeper. And then you use the thicker one to just turn it round in that space. When you turn it round and you learn how to do it, often the tooth just falls out. You don't have to use a forceps, it just drops down in the mouth. Is that good? Okay? You will use it mesially, you will use it distally, and that's the job. You use it buccally, you will be in a problem. Unless you know what you're doing, never use it palatally. Palatally is always a problem because doing this will fracture it buccally and you will fracture your buccal plate. So not recommended. Unless you know what you're doing. If you know what you're doing, maybe few cases down the line you can do it. But if you see, this is how you're supposed to use it. The blue parts are where you use it often, and the yellow parts are where you use it very little. In the lower arch, it's always mesial distal, mesial distal, mesial distal. Okay, very rarely lingual. Then with the 3S is the rotational motion. Once you have space, your thicker luxator goes in and you just turn it around along the root. It just severs it, it loosens it, and just pops out. This is a 2S.
Can we add music at the back of this?
That's all, just little movement. You just want to put it in and just, create a space. Buccally very slightly. Maybe in the premolar you can use it, but not in the anterior segment. Then you use the thicker one, the 3S, and that's the one you use to loosen the tooth actually. Very rarely, if you know what you're doing, you can use it lingually or palatally, and once you move it, of course this is a model, the mouth is not so easy, but still, it's inspirational, right? Okay, just bad. That's why good instruments always help you. Canines are the most difficult teeth to extract, and they are most often ankyloids to the bone. Means when you remove canines, you often break the buccal cord teeth. Much older patients always. In this case, it didn't matter to me practicing the alveolar plate because we were doing a whole arch. In the whole arch, we anyway remove the entire alveolar bone. Right? We cut it off and we work only on basal bone. But having said that, we use the forceps only in the end. It's not the main course. It's the luxation which is more important. So shall we take a small break? Now, implants are considered the basic standard of service. Okay, a bridge is only to be done when there is no other option. Okay, cutting teeth for no reason to take support is only to be done when there is no option. The first choice, if the patient asks you what is best, is always an implant. Now, this is regardless of whether you do the implant or you don't do the implant yourself. Okay, you still have to recommend it because that's your standard of service that you provide. Okay, there are clinics in which you don't do it yourself and you don't have confidence in giving it as a treatment option, but you still either have to learn or get someone to do it because that is still the basic care of service, right? Traditionally, what we used to do before is a two-stage procedure, right? First, we used to extract the tooth, wait for 2-3 months, then we would place an implant, wait for 8 to 12 weeks, okay? And then do a stage 2 surgery, wait for 3 more weeks, and then do the impression, okay? This used to take almost 7 to 12 months. So if you ask the patient, okay, he's saying you want to do the extraction and we'll do an implant, he's going to get the prosthesis almost a year later, okay, which is not acceptable, okay, it's not acceptable anymore. What happens in that time frame? When you extract teeth, everything collapses. First of all your bone loss is dramatic in the first few months. Secondly, what you were talking about, the ridge gingiva, the two tissues start merging and they form something new, a completely different complex called as the ridge gingiva, which is a combination of your attached gingiva, your marginal gingiva, everything together. your alveolus shrinks from all directions, vertically and horizontally. And most importantly, your cortical bone also thins. The cortical bone, which is supporting the tissue on either side, that shrinks, and the medullary bone from inside also loses. Without stimulation, the bone does not survive. Okay, what you call something called as disuse atrophy. Disuse atrophy is the same concept anywhere in the body. If you don't use one hand for 12 months, that hand shrinks, muscles stop working. Same thing with the alveolus. The moment the root is out, it starts shrinking. At the same time, if there's an implant propping the bone up, that area is in use, the bone will survive. Okay, so incessant bone loss and soft tissue collapse is a biological reality. Now, there are different treatment strategies when you extract a tooth. Okay, first of all, you can do a socket preservation, which is a lot of things that they do in the US. Every single socket, they do socket preservation. For them, it is an insurance-based, sometimes, requirement, okay, that they use a graft and they save the bone for the time being. Sometimes, in certain cases, and very few people would do either an immediate placement, an early placement, which is within 8 weeks, delayed placement, which is between 12 and 16 weeks, and 6 months or later. But we are going to concentrate only on type 1, okay, which is immediate placement. Okay. Now, when the patient comes to you for an extraction of a tooth and you suggest an implant as a treatment option, the patient has certain needs, you have certain needs. On the left is what the patient is, what you want. You want a successful treatment to be done. You want the entire treatment to go from start to finish flawlessly. You want it to be highly predictable. You want it to work long term. You don't want the patient coming back every month or every year with problems. And you want a very low complication rate. So that aligns perfectly with what the patient wants. The patient wants the fewest surgeries possible. If you tell the patient that I'm going to extract and place the implant on the same day, he's more than happy, right? That's a very big advantage. Secondly, how much of a pain he has in the extraction, it does not get magnified if you place an implant. It's almost the same. Patient doesn't have any complaints of excessive pain or enhanced pain because you have placed an implant. The healing time obviously is shorter because within 8 to 12 weeks you can start the prosthesis because the implant is already in place. And last is the treatment time becoming shorter is an advantage because you get your charges quicker, right? So from all points of view, it's a go. So there's only one surgical procedure for the patient. You have the maximum bone width and height available on the day that you do the extraction. That is provided you have saved the bone, right? You can use better implant diameters, the biomechanics improve, the treatment time is reduced. Most importantly, for all practices, patients are not lost to recall, and this is a big problem, right? You extract the tooth and you tell the patient, okay, we'll do the implants 3 months later. You call the patient 3 months later and the patient doesn't respond. He said, I'll come, I'm traveling, I'll do it, mere bachche ki shaadi hai, ye hai, wo hai. And you see that patient 3 years later and he's not done the treatment, right? At the same time, if you could place the implant on the same day, that patient is locked to you. Then he's chasing you. When are you doing it? Can you do this? Please do the cap. It's like that. So learning how to do this is an important skill. So the mindset has to change. Someone was asking me about the mindset of an oral surgeon. The fact is, when I was doing it initially, I was doing it wrong. Okay, I was extracting the tooth and trying to place the implant into the socket where we removed the tooth, which is the wrong approach. We are not placing the implant in sockets. We are looking for great native bone around the socket and placing the implant in such a way that it is still in the most prosthetically possible and ideal position. So it's not the socket that we are targeting, it is the bone around it, within the socket and around it, right? So implant placement does not mean that you place the implant anywhere or anyhow and live with the consequences. It has to be prosthetically driven. End of the day, it is still a replacement of a tooth. The patient has not come to you for an implant, he has come to you for a cap, right? So the implant is a byproduct, it is a part of the treatment. So placing the implant anywhere creates more complications than not placing it in the right position. Okay, so if you see in delayed placement cases, how much tissue you have lost. Okay, the width is completely gone. At the same time, if you see cases where immediately you have placed it, you see the amount of tissue you have available. Now these are cases where you have not only placed the implant, but you have also done a temporization simultaneously of some kind. or a customized healing abutment. You've done something. Right? So to harness this biology, learning how to do the implants immediately is critical. Right? Same thing. You see a comparison between a delayed site and an immediate site. There's a huge difference. Look at this. This is what you live for, right? This is the whole game. Creating the natural architecture that was there. You're mimicking the old architecture. So in this case, again, just by placing the implant, doing your biologic, doing a customized healing abutment, you have no graft used, no biomaterials used, but you just have one surgical appointment and you can create this profile. Huge advantage, huge. Okay, now if you're seeing the socket when they heal, okay, the topmost part of the socket is what you call the bundle bone. Right? The bundle bone gets its supply from the periodontal ligament of the tooth. Okay, this here is the most important basis for why you do a partial extraction therapy procedure. By keeping the tooth in place, you're trying to avoid the bundle bone being lost. Correct? Now in any kind of implant placement, if you remove the tooth and harness that biology at the same time, you will lose less bundle bone as compared to situations when you're extracted and you're waiting for longer. Correct? So all these are trying to sell immediate implants to you all. You all understand why you all should do it. So you have the option of socket grafting, you have the option of early placement, you have an option of maintaining the part of the tooth which is called PET, and the immediate placement and allied protocols. Okay, we are going to look at this. Now there are certain rules that are non-negotiable. Okay, first things first, if the buccal bone is lost, you cannot place the implant. Okay, that's important, the buccal bone. Secondly, if you are not able to get the implant in the perfect 3-dimensional position, you cannot continue. Then you have to abort and come again 3 months later. You need good insertion torque on the same time. Okay, by this I mean primary stability. If you're going to load it immediately, you need to have 35 Newton centimeters and higher. But if you're not going to load it immediately and you're just looking at a situation where you're placing it and you're going to leave it in place, you don't need 35 Newton centimeters, but you need it to be stable. It has to be very stable. Your mechanical stability is what you start with. You end up with biological stability, right? So the mechanical stability is the initial part. Then it goes down, like we were having a discussion. At 1 month, the implant is at its weakest. You do not mess with the implant from 15 days of placement to 1.5 months of placement. You don't touch it at all, unless you're removing it, right? If you try to change a cover screw, do this, that, you're going to lose it. This also I learned the hard way. I didn't know this when I was very young, right? There was a patient who was going to the US and I placed the implant on one day and my prosthodontist was traveling. He said, I'll come day after tomorrow and we'll do this and that. So I said, okay, we placed the implant. At that point, I didn't know how to harness the bone around it. I was placing it in the socket, right? So I tried to unscrew it and the whole implant came in my hand. Day 2, and she's flying out that night. So I just pressed it in and kept it. I said, I'm not going to do anything. And I didn't sleep for 4 nights. Okay? She left, went to the US, and she got stuck because she didn't have something with the visa, and so she couldn't come back for 5 years. And 5 years later, she went to a dentist there who looked at the implant and said, this is the most beautiful placement I've ever seen. This is a true story, okay? The best implant placement I've ever seen. It's so perfectly placed, and he did it immediately, and I was like, okay. But that's what happens. You make mistakes, but you learn from it. I'll never ever mess with it after that. You know, you never do it again. Right? You never raise a flap. You never ever raise a flap. You have to do it flapless. The key is to do a procedure flapless. Any gap between the implant and the bone, which is more than 2 millimeters, you should graft, ideally. Okay, there are situations in which I may not graft, but the rule says that you should. And like I said, don't try to achieve primary closure, because when you try to achieve primary closure, and that's the discussion we had, that this is a socket wall. It's not an incision that you have made. Socket walls have bacteria around it. They're rounded. They're not freshened. You don't get primary closure. So if you put in a cover screw and you're trying to get primary closure, it will most likely open up along the incision line. There will be ingress of food and you will lose crestal bone, right? Now the protocol is of either placing a wide gingiva former or I place a customized healing abutment. In some situations in the anterior segment, we do immediate temporization, with a crown, which is left out of occlusion as far as possible. So these are the rules. Okay. In the anterior segment, the concern is always about temporization because the patient cannot survive without teeth for 3 months, right? He cannot have no front teeth. But in the posterior segment, you don't have that problem. Okay, the patient is very happy to be with a gingiva former, very happy to be with a customized healing abutment. It works beautifully. So did you all get this? Okay. So we have already spoken about CBCT software and what to interpret. We have spoken about extraction with least trauma, and we'll talk about drill control, right? Now when you're studying a CBCT, okay, for placing an implant, now this is different from the CBCT that we studied before for extracting a tooth. What are the things that we need to see? Okay, first things first, you have to see the buccal plate. Most cases you will not see the buccal plate because it is usually less than 1 millimeter in thickness, and our slices in a CBCT are around 1 millimeter. So you will not see it, but you know it's there, right? Then you see the lingual or the palatal wall. That's the second thing that you see. Thirdly, you see the root position and the shape. Okay? You see the shape of the socket, the whole block that is available to you, this whole bone. Okay? Now don't look at it as this. This is a mistake I made before, that okay, I'm going to place it in the socket. What I'm looking at is this. You have to look at the bone around it. Correct? Then you have to look what other structures are there. The nerve is there, mandible, sinus is there. All these are things that you have to see when you see the cross section. So if someone sends you a CBCT to interpret, you have to look at it from that point of view. You have to blank out the thing about where the root is, and you have to look for where the bone is. It's like in cricket. I don't know how many people play cricket, but when you're playing cricket, you don't look at where the fielders are. You look at the gaps between them, correct? When you're trying to score. And then you look at where the implant should be. In this situation, I will target the bone halfway up the root into the palatal cortex, right? This is the position that my implant is going to go in. Now, periapical infection. We spoke about this. There's a difference between periapical infection. No periapical infections are the same. Situation like this, well circumscribed infection, most likely I'll remove the root, keep everything ready in any case. If everything comes out and I can see pure bone, I will place the implant. This situation, I will never place the implant. Why? Because this is a post-endodontic infection, which is the most horrible infection you can find, right? It is a mixed infection, most often anaerobic. Okay, it is doomed to fail your implant. It's very rare. People will say, oh, put this antibiotic solution, wash it with metronidazole, put this, nothing works. You're increasing the variables and risk. Okay? In any procedure, the moment you have decided to do an immediate implant, you already have 2 variables which are not on your side. Okay, you're working inside bone which is deficient. The more the variables you increase, the lesser the chances of success. In this same space, if you go and try a bone graft, it will fail. It will get infected. Because you may wash it, you may do anything, but you cannot wash off every single bacteria. Right? So do you all understand the difference? So this is something that I would do, this is something I would not do. Now if you see this situation, okay, now you have a infection which is coming from the periapex, maybe a root pulpal infection. This will be a periodontal infection, and this will be a mixed infection. So which of these will you use?
First one.
I would use this first, this second, this never. Okay? This is easiest because once the tooth comes out, you have a whole crater of bone which you can clean, and your bone here in the where you're going to engage is good. Here, unless I can scoop it all out and I still have bone remaining to engage my implant, I will not place it. I may drill and see. Sometimes you drill and see. So, sometimes there is a gap between the nerve and the tooth, and there is enough bone to engage the apex of the implant. I would still attempt it. But in this case, I would never do it. Okay, because it's usually the J-shaped bone loss that is there, which is associated with fractured teeth, and fractured endodontic teeth, I never use. I never use. It's always a risk. And post-endodontic teeth, you have to always treat them with suspicion because it's the worst and the most horrible infection that you can get. Okay, clear?
So the earlier case also had endo and the lesion there.
Yeah.
Premolar.
Yes.
So, but then
Yeah, but this is a circumscribed infection. It's a localized infection. So once I remove the tooth, I'll keep everything ready. I'll remove the tooth, I'll scoop out everything and see. So then I can do it. This infection most likely was there before the endo was started. But this is not. This is the tooth that's fractured. It's a J-shaped infection if you see. This thing what you call. Okay, so the sockets are different in every single tooth. Okay, you have to look not at the tooth but at the bone around it. And what is the angle at which you need to go? Lower anterior segment, you can see it very clearly that you need to go along the length. So your engagement will be apical but slightly straightish, right? Lower anterior. As you go posterior, your tooth moves more and more lingually, so you have to target the buccal. So if I'm placing an implant in this, it will be in this space, right? Otherwise you will perforate the lingual cortex. Clear? This we have already spoken on, the bundle bone and what it creates. This is a slide of what size implant generally you should use for each tooth. Okay, what is the, depending on the cervical diameter of the natural tooth, what is the implant diameter that you should ideally use? Okay, for the maxilla and the mandible. More often than not, your 3 mm implants or the 3.5 mm implant should be only for the lower anteriors, okay, or the upper lateral incisors. Most used implants will be the 4 mm implants, okay. The 4.5 and the 5 ideally for the posteriors, right? Rule of thumb. Okay. The maxillary premolar. What are the challenges in the maxillary premolars? First of all, the 4s are different from the 5s. Why? Because the 4s have 2 roots. The 5s have a single root. Now, what is the difference between them? In a 4, I will target the interradicular septum. In the 5, I'll target the palatal vault. Right? So when I'm placing an implant for a 4, I will go in the center. But as I go in the 5, I'll go more palatal. Right? Because you're engaging different bone. And one side you're engaging the apical bone, in one side you're engaging the palatal vault. Now in the maxillary molars, again different. Okay, the 6 and 7, 6 generally has 3 roots. The 7th and the 8th often have one root, one big root. You know, they are often conical roots. So again the engagement becomes different. If it is a 3-rooted tooth with bone in between, you're going to engage this area, the interradicular bone. For that, removing the roots separately is critical, right? But in the 7, if you're lucky and you have bone like this, then you'll go in the middle. If you don't and you have a conical root, you have to go with a much wider implant and try and engage the walls and the apex, right? Every case is not a case for an immediate implant, okay, which is something you have to tell your patient on day 1. We shall try, right? I will try to place an implant at the same time. Nahi hua to theek hai. It's fine. Okay. Supposing you even use the implant, you can always return it, right? You don't have to pay for it. It's okay. They exchange it for you. If you attempted and failed, it's fine. But or you can even use it till the drill stage and see whether your drill is engaging. If not, then don't go ahead. Whether you extract the tooth or whether you use the drill, the pain for the patient is going to be the same. It's not going to change, right? Are we clear? Okay, so this is basically in the maxilla. In the premolar, you're going to be in the center, but engaging more towards the palatal. And in the molar, you're going to be in the center of your interradicular bone. Furcation involvement. Okay? Now, in the mandibular premolar, it's different because most often they're all conical. They're never multi-rooted. But at the same time, they're often very buccal. The teeth are always very buccal. So when you're extracting them also, if you move it towards the buccal, the tooth usually comes out easily. But what you are going to target is this area. So the tooth is like this, you're going to go straight in, but slightly on the lingual wall. Right? In the mandibular molar, again the same thing. You have one furcation in the 6, sometimes in the 7, and the furcation often depends on the root pattern. If the root patterns are wide, I'm very excited. I'm very happy because I know I'll have a big furcation. But if the roots are narrow, sometimes you don't have any furcation. Right? In which case, you have to struggle with the placement in this region. When it is very wide like this, the 7s usually have conical roots. Yeah, they are fused and they go tapering in. Then you have to engage the apical bone. But the 7 is often very close to the nerve. So immediate placements in 7 always is a challenge, right? Sometimes it is possible, sometimes it's not. But sometimes when you see the CBCT, you may find an avenue where you can place it. Okay? So in the mandibular premolar, it is always little more lingual than the middle of the socket, okay, because you're engaging this bone. And in the lower molar, it is always the center, which is the furcation area. Is that clear? So this is when you're looking from the top, where you're going. So just some images of implants placed in multiple sockets. Premolar, you can see that in most cases there's a gap. This gap is critical, right? So that it does not destroy the buccal cortical plate. You're always a little lingual because you're engaging the palatal cortex, right? Now these are cases of PET. And the same thing in molars. You can see this perfectly placed in the middle of the furcation.
So with PET you don't need to have that gap.
You do. That is not a very well done PET. But it's just an image, so I was just showing it. You need to have a gap. But you can see the furcation being involved in all of these. Engaged, not involved. That good? So what are the choices we have where we engage the bone? So it is most often the furcation that you engage. Second is the apex, beyond the apex. These are the two areas of impact. And the third is the palatal vault. When you use very wide implants, the walls. That's very rare. Now this is just a slide of the anterior area. If you see these teeth, when you see the cross section, okay, in different cases the bone that you're going to engage is going to be different, correct? Now in this case, you will have to go in the center of the apex, right? Because your bone is only apical. You have nothing on the palatal. Versus this case, you have so much palatal bone that you will be drilling like this, correct? Here again the same thing. It's going to be the palatal wall, but you will be more towards the apex than this case. Here you will be in the middle of the tooth. Here you will be more towards the apex. So your angle will be like this. Same with this. This is difficult to do, but you can do it if you can, because the problem is that you have to go absolutely in the center of this space. And this is difficult to do immediately. Sometimes you have to remove the tooth, do some grafting buccally, and then use it. Okay, it's very difficult to do it immediately at this time. So you have to basically select the case well, and you have to understand what you're doing. Like I said, don't look at the tooth, look at the bone around it. That is the critical step. So it is very important to preserve the bone because we are going to use it for implants, right? And once you remove the tooth, cleaning the tooth is critical, the socket. Now this is a step which most often people neglect. They remove it and they are so happy that they removed it, they start putting the implant in. But the granulation tissue that is there is the one thing that is going to disturb your entire process. So now you have multiple instruments like this. In fact, there are some very nice serrated curettes that you get. They've suddenly started being available everywhere, and you should buy one. They don't cost much, but they clean it very thoroughly. So you have to keep cleaning it till you see complete white bone. That is critical. You have to have the socket so clean that you can see white bone. And that you can check by putting in a gauze that there is no bleeding, there is no soft tissue in the socket, and the thing is absolutely clean. There are some degranulation burrs also you get, but what happens with them is that you tend to cut a little bit of bone, which you don't want to do. Right? So cleaning the socket with tissue is important for all extractions. All extractions. You should be that case, you have to clean it thoroughly. Okay? You will spend 45 minutes cleaning it and 5 minutes doing the extraction. It's like that. Because it has to be pristine. Only then you will have a possibility of doing an implant later. Otherwise, no. There are some other available tissues which you inject some dye which picks up on the granulation tissue, and then you use a laser to clean it, which is also an option because it creates biological cleaning of the socket, which is an option. But the technology right now is not available to all, and it is expensive. So we'll see. Okay. So like we spoke, you never raise the flap. You work occlusally. You don't reflect the flap at all because you're trying to maintain the supply for your implants, right? The selection of the implant is critical. You have to select an implant which is active. That's very important. I mean, the threads should be beyond the body of the implant. The design of the threads is critical because it has to engage the bone, because primary stability is the clincher in immediate implants. And secondly, the apical self-tapping ability is a must. Okay, a lot of implant systems I reject using because they don't cut apically. Okay, they don't engage apically and they don't have apical grip. When you're tightening an implant, you should feel that tightening in the bone, because I'm going to temporize it, I'm going to use it, I'm going to leave it for 3 months. That implant has to be super stable. So the implant design is very important. So if you see something like this with a rounded bottom, I would reject. I would never use it. These two, the TS3 and TS4, excellent implants for placing immediately. And my biggest, the implant I love the most is the SS. I use it for all posteriors. I love the SS implant because A, it is transmucosal, which I think is a great advantage because the connection goes above the soft tissue, above the bone, and it works just beautifully. Secondly, it is a single platform implant, so all the components remain the same. So it's not popular because it's not one solution for all, but for posteriors, I think it is a fantastic solution. And it is also very active and stable, so it's a fantastic solution. But the TS3 and the TS4 work beautifully for this indication. Okay, so we spoke about the areas of implant stabilization. One is beyond the apex, critically. Second is the furcation, of course, or the interradicular septae. And the third is the palatal vault, the area where you're going to engage on the parallel side. So this is the classification by Tarnow and Smith for placing posteriorly, type A, type B, type C. One is when the furcation is so large that the implant will be well contained within it. Two is when it is thin but the implant can still be retained in the interradicular space, but you will need to graft around it. And three, when you use a wider implant and engage the walls of the socket, okay, to engage, and the apex, all three. Now these are all molar extractions as immediate dental implants in the molars, right? Maxillary molars.
So can you go to the previous slide?
This previous to this?
Sir, just a question. Suppose if we have a predentulous case, where the crest of the alveolar bone will act as a guide. Okay, my implant will be either subcrestal or supracrestal or ecrecrestal. In immediate implant cases, sir, what should be the guide?
I'll tell you. It's coming up. Okay, so these are where, see, when you're looking at immediate placements, you have to see the final goal. The final goal is that your implant has to have a crown on it. That crown will have an access hole, which the lab will make for you. That access hole has to be in this position. Can you place your implant in the position that your implant, the access hole will be in this position? That is the determining factor whether you place that implant or you don't. Okay? If your implant is going to be here, you don't place it. If it's going to be here, you don't place it. You understand? At that point, you have to abort the procedure and stop. If you can place it in a way that prosthetically it is going to be in the perfect position, only then you continue. Sometimes you don't place the implant in spite of getting engagement and everything, because long term it's going to be a headache for you. Another thing which is very critical, and this is something that we have spoken about, is drill control. Now, placing an implant in a mature site is completely different from placing an implant in a socket or in bone where the tooth has been removed, because it's like basically placing it inside a hole, right? When you're going inside a hole, there are multiple places where your drill can go. You don't have a stop or you don't have a place where you have to engage. For that, you have to create an engagement, right? You have to create a spot where your drill will not move. For that, drill control is critical, that your hand has to use and your instruments have to use, right? So you have these two instruments which are beautiful. Osstem has a fantastic lancet drill. Okay, it is one of the best drills I have seen. Okay, you use this lancet to make a purchase point. The whole job of the lancet drill is to make a purchase point so that your drill does not slip. So you use that lancet drill and engage to 1.5 to 2 millimeters just to make a little bit of a stab. Okay, you don't have to drill with it, you just have to create a stab so that from then on in, your burr does not move, right? Second is the Lindemann drill, which is a very serrated drill. Now the purpose of the Lindemann drill is to shift position. If you're not in the right angle, you can change it with the Lindemann drill. Side cut, because it can go in all directions. But it is a very aggressive drill again. So unless you're 100% sure, don't use it. Osstem has a fantastic kit. Their kit is, I think, leaps and bounds above all other systems because it has a inbuilt stopper, which is invaluable, right? If you're drilling, you know exactly what length to drill. Having said that, you have to use it to your advantage. If I'm placing a 10 mm drill implant in an immediate socket, I'm going to use 11.5 drill because the stop will stop it. I don't want that. I want to have a little bit of leeway, right? So I will use a slightly longer drill while doing the osteotomy so that I have a little bit of space. Okay, little more subcrestal, and at the same time, I'm also having that little 1.5 millimeter advantage. Okay, if something comes in the way, because you're using it inside a socket, don't forget that. What if the palatal wall is crashing into it, or you're not able to get it in the right position? You have to be able to go up to the depth of the implant that you want to drill. So sometimes you have to use the drill to your advantage. So you use a slightly larger drill, slightly longer drill to get into the right length, right? So that is of course with clinical judgment. All other systems don't have a stopper, which is even more dangerous, right? That makes it very dangerous because you can go all the way inside. Sometimes the bone is so soft that you go through and through. And these drills are very aggressive. So you have to have a lot of control, right? So you have to use these two to your advantage. One is to make a stop or a purchase point, and two, to drill to depth or to change the position. So basically you use the lancet drill to just make an engagement. So sometimes when you're going in with it, you don't go straight. You go at a slight angle just to make the ditch. Okay? Once you have the ditch, then you straighten the drill and go up to depth. Are you getting this? It will not slip. Once you have the little bit of a purchase point, then you straighten the drill and go straight in the angle that you want to go. Is this clear to everyone? Because this is the most critical stop. Because straight sometimes it slips. You have to understand that when you're working on a interradicular bone is not flat. It's often sharp. Okay? So there are two ways to deal with this. Either you flatten it or you engage it and then straighten it. Okay, both work. But to flatten it, you're again losing a little bit of bone. So that, that discussion is about how. So this is what we do. When there is enough bone, we just use a round burr and just convert it from convex to concave. You are understanding this? I've used it on the interradicular bone to convert it from convex to concave. Now the chances of the drill slipping are less. So this is a critical step. Also you see this, what do you see here? A pencil mark, which I use even today after 30 years. If you make a pencil mark, it doesn't get obscured with blood. So autoclave a pencil and keep it. This is just a tip. I don't know how many of you all use it. Do you all use it? So use a pencil to just make a small dot. Nothing happens because you're going to drill through it anyway. At least you know what you're aiming for. Okay, if you have a target to hit, you will hit it. If you have anywhere to go, you will slip here and there. So with this pencil mark, I will always put a pencil mark. I will drill 1 millimeter in or 1.5 millimeter in. Then use the next drill at the angle at which I want my implant to be. Correct? So this is for maxillary molars, right? Are you all understanding this? Again, marking it, the initial punch with the lancet drill, and then you dictate the angulation and then go all the way. In the mandible, same thing. Flatten it slightly, do the initial punch. Now if you see the initial punch again, it is at an angle here, but when you're drilling it, you're almost going vertically down. Right? So why you go at an angle is because it gives you that little bit of advantage of marking it. If you go straight, you will destroy the bone if it is convex. So you just go at an angle and just make a little bit of a stop or a slip. Then you go straight and go through and through. Clear? Yes. So this is the one of the most critical steps in placing it. If you get this step wrong, everything ahead is gone. Your bone is gone. It's finished. That chapter is closed. Then you have to call the patient 3 months later. Right?
So sometimes even after you call the patient after 3 months and you take a CBCT also, the bone in the molars mostly, the bone has not
So that is a fallacy. See, what happens is the bone may have formed, but for it to be apparent on a CBCT, you have to wait for 6 to 8 months. It is never seen on a CBCT, but there is bone. So this is the time when you can actually give a little LA and check it with the probe, actually. Because the bone forms, 3 months is decent bone. It's not the greatest bone, but it's decent. You can place an implant. But it is never seen because the ossification is not complete. So don't rely on a CBCT always. Rely on the time. Okay, so 3 months ho gaya, you're ready.
For every patient?
Every patient. Any X-ray. If I do a cyst today and I call the patient for a checkup, I tell them do not do a scan till 1 year.
Correct.
Because you cannot make out, it still looks like a gap. But at 1 year it shows whether it has healed or not. So who was asking me about the depth of the implant? Someone asked a question just now. Yes. So what you have to do ideally is you have to place it in a very ideal situation to the top of the interradicular septum. But you have to make sure that this distance from the CJ, okay, is 3 to 4 millimeters of the adjacent teeth. The depth. So your 2 teeth are on adjacent side or in 1 tooth on the adjacent side. Your implant should be at the top of your furcation or interradicular bone, and it should have a gap of 3 to 4 millimeters. Why you need this gap is because something called as running room. Running room is for creating your emergence profile, right? It's a prosthetic term for creating emergence profile. So your most coronal aspect of the septal bone that you have, that's where your implant should lie. Okay? The root length, that is what we decided ekdam first when we started, the length of the root. The root length determines the absolute available bone for safe placement. Looking at the scan, you know whether how much bone was there to begin with, right? And you have to avoid the anatomic danger zones, which is your nerve, your sinus, and your nasal floor. 3 things, right? The tooth width and the coronal and CJ determine the width of implant that you need to use and the running room to develop great emergence and avoid a ridge lap. What is ridge lap? Is a cantilever, right? In certain situations. So why we are talking about flattening it and making it? Because if the position is here ideal and you have created an osteotomy here, you're going to have a buccal cantilever. Now why this situation occurred is because you didn't flatten the ridge. If you flatten the ridge and create a concavity, you will never make this mistake. So what happens is there is a diversion of the drills when you're working, and it happens very often, even today. The drills slip when you're working on a smooth surface. So you have to create a gap where you drill is engaged and then it will not slip. So just an X-ray of an implant done inside a socket. Okay, here in this case we are engaging only the apical bone because the socket is wide enough, right? So just engaging the apical bone is enough to get primary stability in this case. And you can see the position. The neck of the implant is almost 1.5 millimeters deeper than the adjacent bone, right? Now in this situation, the root has been extracted, but the position that is ideal is not in the socket, but it is engaging this bone. Now this is a mandibular case, right? You are engaging bone which is here, which is on the side of the socket. So the implant position, though in this X-ray it looks wrong, it is actually ideal. You know, because I am engaging. Yeah, the risk is there. When there is a canine adjacent, it's always risky. But the canine always slopes. You have to be very careful about that. Clear? So people post images on social media with X-rays like this and like this, but I find them wrong because once you have gone into a socket while drilling, which most often happens, that means there is going to be a huge cantilever in your prosthesis. Okay, so at such points it is better not to do the implant and delay it if possible. Okay, sometimes you will leave it, but in that case you will have to customize even the abutment when you are making it to cover that whole gap, because otherwise the patient will always complain about food getting stuck. They will always keep complaining. Food is getting stuck every time I eat, because the implant essentially is narrower than a tooth. You know, even if you use a 5 millimeter implant, it's still narrower than a 10 millimeter tooth, right? So there is always a gap. Okay, you can circumvent it by making a customized abutment, you can do this, you can do that, but still it's always going to be narrower, unless you place 2 implants, but then it is overkill, right? So if you place it in the palatal socket by mistake, which happens in the upper jaw when you're working, then you're too far angulated and the whole crown is buccal cantilevered. So the patient is always complaining of food getting stuck on the outside. And in the lower jaw, if you're in either socket, either the mesial socket or the distal socket, you always have a cantilevered crown. So these are things that you should try and avoid. In this situation, it is not a bad placement. Why? Because this tooth is inclined, right? So you're still in a decent position for making a crown, and your crown is going to be all the way till here anyway. Now another thing, something called as finger rests. Now when we were learning dentistry in college, we were always taught to use your finger rest while placing, right? You use these 3 fingers to engage and you place the implant. You're drilling your burr and you're cleaning out the teeth. In implants, it is counterproductive. Why? Because you're using something very long. The drills are much longer than your normal burrs. So what happens is when you use a finger rest very close to that area, you end up inclining it like this. This is exactly what happens. You understand? So what happens with that is an implant which goes across and often disturb the adjacent teeth. So this is a mistake, and it's because of our habit of holding a drill, taking a finger rest and working. When you're working with implants, you have to have a remote finger rest. Remote finger rest may be on the opposite side of the arch sometimes, with the burr, or you have to use it freehand. That's how it goes. So this is not related to imaging implants, but it is something that I thought is worthy of sharing. Right? You have got extraction of imaging implants. Varieties of lint implants. This is So what this video is trying to highlight is the angle at which you drill. So when you're doing it palatally, you will often go, almost like this first, make an engagement and then straighten your drill and go straight, because the angle at which you want to place it is like this. But at the same time, if you go straight like this, you will strip the wall, which you don't want to do. You want to make a hole in the wall, the palatal wall, but you want to go with that hole then deeper. Are you understanding what I'm saying? No. I'll see if I have some slides for that later, right? So there is a whole theory about grafting the gap. When should you graft, when should you not? In presence of infection, you never graft. Okay, first things first. If there is infection, if you have placed an implant, I don't graft, because I don't want to introduce one more variable which is going to get infected, right? And bone graft will get infected more than an implant, because implant is stable. Bone graft has mobility in it, right? Anything which is stable will not get infected. Secondly, you have variety of grafts that you can use. Okay, you can use autogenous, which is ideal. You can use allografts. You can use synthetic. You can use xenografts. Okay, in an indication like this, in a socket where there is walls on all sides, all of them will work. All of them. So there is no harm in using any of them. My personal preference is to use autogenous or allograft when it is in contact with the implant, and pack the rest with a xenograft, my personal preference. But having said that, everything works. Okay, the bone graft, whatever you use, eventually gets replaced with bone. Okay, if you don't need to use a bone graft, don't use it. If you feel the gap is not wide enough or there is not enough engagement or it's not going to stay inside the socket, then don't use it. Because when you use a bone graft, the most critical thing is how do you retain the graft inside the socket. That is the critical thing. Putting the bone graft into the socket is the easy part. How will you retain it? So there are various ways to use it. There are these collagen plugs which people use. They place it around it. They engage it. There is, you first of all try and do a primary closure, which is one option, but that is not ideal because you're trying to advance the flap so much to close it, right? Secondly, you use wide gingiva formers, which I do often. You use a wide gingiva former which retains the graft in and then you suture around it. Third is you make a customized healing abutment. There are various types of customized healing abutments. We'll see a few cases later on. Biomembrane, which is membrane that you use, your tissue membrane that you use, GTR membrane, which you can use over it, but the disadvantage is that they resorb within 15 days. So they don't remain for long. There are some people who use soft tissue graft. They harvest a connective tissue graft and then they place it there through the gingiva former and they stitch it on all sides. That requires a lot of skill. I don't know how many people can do it on a consistent basis. Harvesting the graft and then going through it, placing it in the implant and then suturing around it is difficult to do. Then there are these two things which I don't really like. There's something called as a poncho and a composite bandage. Composite bandage is when you just inject composite flowable around it and hope that it works. But the problem is in the mouth it stinks. The composite, even if it stays, it stinks. And poncho is when they use a sheet of rubber dam. They cut a sheet of rubber dam, they sterilize it and they suture it on all sides. That also is horrible. It really smells. So given a choice, I would use these two. Either a gingiva former or a customized healing abutment. If you're placing a graft, you have to do these. You can't leave it without that, right? If you can get primary closure and you have the skill to advance the flap and close, that's great. But if you don't, you will have to use one of these two.
Customize is again with composite only.
Yes, but you're making it with not a gingiva former, but a temporary. Yeah. You have to polish it very well. So this you all should take a picture of. This is what is important. This is the whole flow chart of how you proceed with immediate molar implant placements, right? First of all, you have to have skilled and experienced surgeons, okay? Then you need a pre-op CBCT and selection, correct? Secondly, a flapless or minimum flap reflection. Thirdly, atraumatic extraction, in which you do a decoronation and then section the roots. Step 4, use the interradicular septum for implant placement, right? Step 5, site preparation with tapered burr or bone tap osteotomes. Use 4 to 6 millimeter wide, slightly tapered implants and also active implants. The implants that you place have to be 3D positioned and 1 to 2 millimeter subcrestal at buccal and lingual, right? Ensure implant stability. Graft the gaps as appropriate. Soft tissue graft needed for thin layer biotype. When the biotype on the buccal is thin, often a lot of operators put a little bit of connective tissue underneath to thicken it up, because now the entire accent is going between only the bone is important to now soft tissue and bone are both important, right? So the whole accent has now changed. So there are a lot of operators, what they do is they open a pouch and they put in some connective tissue to thicken the gum, because that stability gives more stability to your healing implant. Submerged or non-submerged healing, right? And last is the final X-ray. This is your flow chart for how you want to proceed. Okay, we'll go through a few cases. Okay, we'll see, right? So this is a dear patient of mine who I've worked on for many years. Okay, she came with an entire bridge here which was broken. So this tooth we could save. We did an endo and we decided to save it. These two are going to be extracted because they were not restorable. So if you see this spot, easiest to place, no problem, right? This part I had to extract this tooth but place the implant here. This spot again no problem, it's nice wide bone. this spot I was going to engage the interradicular bone. Okay, so this position of implant is here, and this position of implant is like this. If you can notice, it has a slightly palatal inclination. Maxillary implants, you always give it a little bit of palatal inclination. Okay, so raise the flap, extract the teeth atraumatically. We cut the tooth and remove it. There are 3 sockets. What we are targeting is this area here and this area here. Okay, 1, 2, 3 and 4. Correct? So I think we have done pretty well. 1 implant here, 1 implant here, 1 implant here. Now if you see this, this is the immediate placement which is palatally placed slightly. This is crestal and this is engaging the interradicular bone. Okay. Now this we buried inside and we allowed it to heal, and few months later we did the stage 2. Correct? And then this is the final prosthesis. So in this you can see that the position when the bone is mature is different from the position of the implant when you are doing an immediate, right? It goes slightly more palatally, and in certain cases where there is a interradicular bone, you go in the center of the interradicular bone, but with a palatal cant. It has to be palatally inclined. So basically you are going through the furcation, through the interradicular bone. Okay, another case. Now this case there were 2 teeth. Okay, these are mandibular molars. One tooth is missing. One tooth is it's a fractured tooth which has a little bit of width. In this case we have cut the tooth into 2. If you see the X-ray, there is a large furcation here which I can engage, interradicular bone which I can engage, right? So our plan is to place 1 implant here and 1 in the center here. Can you see this? I am very excited when I see roots like this which are wide. So I can see the interradicular bone and I can target that. This is the actual osteotomy which is done, and 2 implants are placed. Correct? Another case. Now there is another technique we use called as a DTR, drilling through the roots. Okay, now when there is a nice wide root and you have nice bone in the middle, we just cut the tooth and we drill through it, because the actual scaffold of the tooth gives you support to the drill. It doesn't move, right? So it acts as a guide almost to place your implant. So when you see a situation like this, it's an ideal situation. You just cut this root into 2 and you target it in the center with the drill without removing the roots, right? You drill in the center, you take an X-ray, you see whether you are in a good position. But the most important thing with this is that you have to be good enough to remove those roots. You know, that is the critical thing, because a lot of people struggle with that. They get everything in the right position, but they can't remove the roots because they are difficult to extract. Because not only they are cut, but now you have also thinned them out. So you can see it's perfectly in the center. I'm very proud of this picture. So implant is placed. So a little note on osseodensification. We have spoken about this before. Okay, osseodensification is this whole system where you use these specialized drills in a reverse direction, and it basically densifies the bone. It takes the bone that you're cutting, and without being an resective drill, it's an additive drill. It pushes the bone to the sides and plasters the bone on the walls. So there are advantages to this and disadvantages. The advantage is that the bone becomes thicker according to you, and the primary stability is far better. But sometimes what happens is you're basically plastering dead bone on the walls. So that basically sometimes creates a problem in your stability and in the healing. You understand? So you have to be careful with this, but in a lot of cases it's beautiful to use. So you use it in the reverse direction. There are specialized drills. Okay. Most importantly, you have to only use it in the maxilla or in situations where there is a lot of cancellous bone. You cannot use it in cortical bone. And the cancellous bone, by rule, has to be 2/3 of the cortical content. Means you need to have 2/3 more cancellous bone than cortical bone. Do you understand that? If there's this much bone, you need that much more cancellous bone and only thin cortical bone. If you're using it in the mandible, in the maxilla, it's usually not a problem. But the advantage is that you can widen a space where you had 2 millimeters bone. You can now place a 4 millimeter implant because you can widen it. Right? But anywhere there's a cortex, you have to be careful because it destroys that. Also, it can never be used on grafted bone. If there is a bone graft that you have used, you cannot use a osseodensification method because that's different bone from natural bone. Clear? But the advantage is a thin furcation like this, you can make it this thick. Where you would have not been able to place more than a 2 millimeter implant or a 3 millimeter implant, you can place a 4.5 or a 5. Because if you use it well, it does really well. Like this is a case where there was a crown which we removed and the root we had to remove. So we cut the root and removed it and we mark it with a pencil, as you remember. And look at this space that we create with the densa. Also, the densa used properly can also do a sinus lift for you, an indirect sinus lift. Sorry? No, unless you have that much more cancellous bone. And in the mandible, posterior mandible, sometimes you have it, sometimes you don't. But you can use it. In the furcation, most often you can because it's cancellous bone. But you can't use it for regular placements. Then I will use it. Okay? So this is the next, sorry, is there a question? Something like it, their version. Huh? They want you to not go outside this building, right? All your money should get over here, which is fine. I mean, it is one of the #1 companies in the world. It's surprising they don't have something like this. They should. See, this is an innovation by Salah Hoes. Let's give him credit. Okay, it's not an Osstem product, I accept that, but it is a brilliant product. It has changed the way we look at indirect sinus lifts. Okay, it's changed the way we look at ridge expansions. It's changed the way we look at height, width, everything. It's a brilliant product. There are a lot of Me Too products. Why should a company like Osstem, which is doing such brilliant work, not have an alternative? You know, it has, see, a lot of indirect sinus lift kits have become redundant because of this product. So why not have its own? And Osstem is an innovative company. They've done some of the most fantastic work. And it is a leading company. It should have a product like this. I'm surprised they took so long, frankly. They should have bought out Salah Hoes at that time. Okay, anyway, so this is another case. Okay, 4, 5, 6. So the approach for extraction of all three is different, right? 4 I'm going to divide and remove. 5 I'm going to remove whole. 6 I'm going to divide and remove. Correct? So I've split it. This I've split like this. This I've split like this. And this is intact. Now the tooth is out. You can see the widening with the osseodensification. Can you see it? It not only gives you that width, but it also gives you tightness. So if you use a drill up to 4.3 and then you use the 4.3 or 4.5 implant, it engages very tight. You get great primary stability because you have not only drilled it, you have plastered the walls with it. The only thing you have to be very good with irrigation. The irrigation on your drill or the handpiece has to be very good. Okay, you can't have less irrigation because you will overheat the bone. And you cannot use old densa burrs. Any burrs that you use at the manufacturer's prescribed time, you have to change it. Right? I've been using it from 2017. I must have bought at least 10 to 15 kits till now. Changed it again and again and again because after some time it starts giving you trouble. It doesn't do the job. See this, look at this. You saw the furcation how it was. Look at the furcation here. And look at it here. I mean, this is stunning and it's in exactly the correct position, which would otherwise not have been possible, right? But here we used just gingiviformes, large ones. Another case, same thing.
And leave that gap open.
Yeah, I left the gap open. See, the debate between using cover screws and gingiviformes. Now I've tried both. Now with cover screws, what happens is, because you don't get complete primary closure, often food gets in the middle and you'll start losing bone. Okay? With a gingiviform, because it is anyway open, it washes out. There are cases in which you'll do a normal implant, not immediate, but you will do an implant which you have opened the flap and put in. After a few days, if you see, you'll see a little bit of pus escaping from the crest. So what do you do in that case? Irrigate. But the ideal thing you should do, if there is stability, is change it to a gingiviform. That will immediately solve your problem. Because it remains open, it washes out all the pus, all the debris. At the same time, your stage 2 is done. But you have to be sure that the implant is not mobile. So you have to be very careful at when you do it. So doing the stage 2, I can do it right now, or I can do it after 2 months, right? So if the patient is available to me, why would I not do it? When there are patients who are overseas patients, and all, sometimes you say, okay, I'll bury it implant. Then I'll cut the margins, I'll create that space and then bury it. I'll try and get primary closure. I'll use specialized suturing techniques to close it. Something called as a modified Laurel suture, in which I'm closing the tissue tight. All that I'll try. But in a situation where the patient is around and I can check him every 15 days or a month, I put a gingiviform.
Sir, do you use any antibiotics or solution or something for the irrigation?
No, never. I don't believe in them. Some people do, I don't. Because I feel the antibiotic which you use from a tablet is meant to be used in the tummy. Localized ones don't work, and topical solutions that you use never remain in contact for long enough.
No, you can do bottles or vials also.
I don't think they work well. Means my experience is not that great with them. I've never.
No, in periapical.
I just wash it with saline.
Remove the granulation.
You clean it like mad, but you first wash it with saline. Right? Another case, upper 6 and 7. Okay, you can see the 6 is multi-rooted, 7 is conical. Can you see that? So here I'm going to target the interradicular bone. Here I'm going to target the apical bone. Okay? You cut it, extract it. You take this furcation with densa to this. Can you see that? But here I'm going apically. So my whole osteotomy has moved lingually, palatally. Can you see that? It's shifted. Because I'm engaging the bone which is apical. Here I'm engaging the bone which is interradicular. So see this. This is the point where I want to work, and this is the placement. Again, at least here we have used wider gingiviform. The other cases we learnt. Initially we were using whatever was available. Then we planned for it and we were ready with it. But everything does not fit. Like sometimes when you try with this situation to put a wider gingiviform, it interferes with the walls. So unless you customize it, it doesn't always work. Right? The regular gingiviforms which are available from the company sometimes don't go all the way because there is bone interfering on the sides. And you can't maintain like 50 gingiviforms. You have to use 1 or 2. You will open 1 packet, 2 packets.
There is no sinus case in that case.
We didn't need to. See, even with a sinus lift, if I am raising the lining by 2 millimeters, I don't need to put a graft. I don't put a graft rather. There is a whole accent on seeing that dome. People like to see that dome, do the implant. I can do that every day of the week. But do I need to do it? No. Because putting an implant plugs the gap completely, right? It is the best plug that you can use for a hole. Because the osteotomy that you have made is of the exact correct size. Your implant is wide enough to engage it tight. So there is no leakage. The chance of getting oroantral fistula is almost zero with an implant in the plug. And the bone that you see, even with a sinus lift which is done, when you have a dome above it, if you see that same X-ray after 1 year, it's never a dome. It's thin cortical bone which is just attached to the implant. I can get the same effect without it. In DENSA, there is a concept called as autografting. When you're working with DENSA, it pushes the bone apically also, as well as on the side. So in a lot of cases, we don't graft it. So again, another case, Now these all look the same, but I'm just going through them so that you'll see what happens, right? Again, excited to see this space in between the roots. Okay, so you cut the tooth the way we planned. This is my lancet drill, this is my Lindemann drill. Both are in place, engaging the area. Take an X-ray with it, right? I've drilled just one drill short of what I would otherwise do. Okay, then I've extracted the teeth. Like I said, you have to be good enough to extract the tooth without destroying your osteotomy.
Sir, any specific plan to remove such type of thing once the root gets out?
You have to use only luxation. You can't use the forceps. You have to do only.
Does that affect the osteotomy while you push it into the?
Again, you do not use it in the middle. You don't use it in the separation. You don't use the luxators in this area only. What I use is I use it here, I use it here, and most often I use it buccally and lingually. So basically, using the luxator lingually is something that you have to be very careful about. But if you know how to do it, it is a game changer, right? Because that gives you that added advantage. The lingual cortical plate in a lower molar is the one which holds the tooth in place most often. It's not the buccal cortical, it's the lingual. So when you release that gap between the tooth and the root and the bone, it just lets the tooth pop out. So you have to be very careful, but if you're good, you can just place it here, the luxator, and it'll just pop out your tooth. Okay, so 2 implants placed. In this case, we placed cover screws and we buried it. I don't remember why. But just to know how to make a customized healing abutment, okay, you have 2 options. There's one, either you use a temporary abutment or you use something called as a cylinder. Okay, both of which are available. Okay, now this is made in plastic, this is in metal. Now you have 2 options of making it. There are some labs which make this for you. It's a small shell. If you tell them which system it is, they send you something which basically is of different shapes. You get premolar ones, you get molar ones. And Vishal is here, he can help you with this, right, from the Dentocraft lab. So these shells are sometimes ready-made. So all you have to do is once you place the implant, you place the plastic abutment there, you place this over it and then just seal it with a little bit of light cure. Okay, this is another thing which is available. Okay, you get these from some companies, they are templates. You need a implant analog and you need the abutment, you place them in, you place it in between this and you just flow some composite around it, right? Then you remove it and you keep trimming till you get it in position. It's consuming, and the most important thing is that your thing has to seat in fully, your abutment, and the thing at the bottom, your composite has to be very highly polished. So you have to be very motivated. That's why prosthodontists do it, right? So this is a template, like how this is ready-made and comes from the lab. You don't need to use this always. You can use a implant analog, use this template in the middle, and you put the temporary abutment.
The analog will be facing us.
No, it will be at the back of this. Yeah, this is your abutment. The analog is behind the template. It's hollow, right? It's got holes in it. You put the screw through, you flow a little bit of composite around it, okay, then remove it, try it in the mouth, and you keep trimming till it is fully seated with your X-ray. Right? You get multiple shapes. Depending, you can use it for premolars, you can use for anteriors, you get multiple shapes. So this is a case in which this ready-made template was there. Okay, we place this temporary abutment, you place a little bit of composite and you seal it in place. Then you cut it at this level. The advantage is that it is already pre-polished. That's the big advantage. So it saves you a lot of time. Having said that, it has to seat. The most important thing is it has to seat. But when you're doing a bone graft, you have no choice but to do something like this. So you have to pre-plan this. And you have to keep enough time because it takes a lot of time to do. Right? And you have to always maintain it out of occlusion, otherwise you'll be loading it. The advantage is that the tissue that you form is beautiful at the end, and you can recreate that in your scan, and you recreated the anatomy when you're doing the final crown. See this?
You don't need to give a membrane after the bone graft.
No, this is sealing it, no? Completely. The advantage is that it's a biologic seal using a customized healing abutment. See this, you can see the bone graft slide fragments everywhere. Can you see it? and the final crown. Okay, one more case. Okay, now this is a case of a maxillary molar in which there are 2-3 things that you do. One is a DTR, indirect sinus lift, and a customized healing abutment. Right? So you do your planning. What is this? You need to do an indirect sinus lift in which you raise the lining slightly. You drill through the root, what you call as root guided osteotomy, or drilling through the root, DTR. You check it with the X-ray. You don't go all the way because you don't want to puncture the sinus floor. This is what you see after you have finished your enlargement. Then you remove the root, section and remove the root. Then you see the furcation, the osteotomy, whether it is in the right position. Then you widen it till the implant, and you do a indirect sinus lift, both. Okay? And then you place the implant. This is another type of customized healing abutment in which you just put a temporary abutment and flow composite around it. But then you have to keep removing it and trimming it and polishing it perfectly. But it provides a socket seal for the bone grafted. It's an advantage. You can see the indirect sinus lift done there. And the final crown. Okay, so coming to the end almost. So we have the complications. They are the same as anything else, right? The implants can fail. Implants will, this is the most common, improper angulation, injury to structures, most often the inferior alveolar nerve, mobility and loss of implants, most commonly, right? Because you're placing it within a gap. But at the same time, it is the right thing to do. It is the appropriate thing to do. So given a choice and given the ability, please develop the skill to do it. It's important. It's a very important adjunct to our skill. Right? Thank you. So now if there are any questions. Yeah.
Here we are doing customization just to avoid the second stage, or
No, we are doing it to hold the socket in place. We are doing it to create an emergence profile which is ideal and to avoid the second stage, all three.
what if we just put a covers to and suture it up? And
You
then-
can, but then you have to do a stage 2, but you can't close it. When there is a graft and it's a socket, it's very difficult to close it, and primarily in such a way that your graft is still retained. Even if there's a small gap, it will keep washing out. You can do it, but again I told you the same situation. When you're trying to suture a socket, you never get primary closure. Even if you mobilize the flap and close it, there will always be a gap. And that most often creates a little bit of pus, and food gets in and gets infected. So to avoid that, something like this works better.
So can you brief us on anterior?
I have a presentation on it, but it will take too much time. What do you want to know?
Just the steps after placing the implant. Temporary cylinder.
To do a temporization, the same thing. What do you want to know about temporization?
Yeah, just few steps on how exactly to proceed after placing the implant.
So do you want to make the temporary in-house?
Some places where they write about rubber dam and then placing the temporary.
So that's what I'm asking. Do you want to do the temporization in-house, or you want to send it to a lab? There are two options. Correct? So one option, if you want to do it in-house, what you have to do is, after you place the implant, okay, you place a rubber dam to seal it, because whatever material you put will flow everywhere, right? So you put a rubber dam sheet, you put in your abutment there, the temporary abutment through the rubber dam sheet, you flow composite around that so that it's attached to the temporary abutment, and then you remove it out, remove the rubber dam, you clean up and shape the temporary tooth and put it back in. That's what you do. because that is the only way you will avoid your composite going into the socket. Sorry? So then you just record an impression. So what we do is, you just record an impression. Your implant is already in, okay? You put in the impression post, take an impression, put a gingiva former, send the patient home. The lab will do the job. They will put in a temporary abutment, make a screw retain temporary for you, and you place it the next time. But you have to do it within 72 hours, ideally. Okay, you can't delay it. So the lab has to be sounded out before, they have to be ready. Your temporary abutment has to be in place. You can't do it, okay, I'm doing it now and now I'll order the temporary abutment from the company and then I'll send it to the lab. All that doesn't work. You have to be prepared. The labs make fantastic temporaries, something that you can't replicate. Patient has to be without teeth for 24 hours, which they are okay for, right? But that is what we do now. Very, very rarely there are patients who are very finicky and they say, I will not go without a temporary tooth in my mouth. Then I have to do all that stuff in the clinic. But that is very time consuming because whatever you make has to be perfectly polished. Because once you tighten it, now you don't want to unscrew and tighten every time. So you have to do it right one time. So making a lab-made temporary is better. You tell the patient that for 24 hours you will not have teeth, that tooth will not be there, manage, and they do. But someone said?
Just make a temporary from the lab and then...
You can, but then your position is going to be that perfect. Unless you're doing it guided, then you can do it. That was the whole concept of the guided thing, that you keep a temporary ready, but then your position of the implant has to be that perfect, which is never the case. You know, it's very difficult to replicate.
Sending it to the lab is like how we usually do it
Yeah.
for finance.
Except the fact that the implant is just placed on the same day. So you have to be very careful while putting the, if you're taking my analog impression, you put in your impression post, you record an impression, you remove the post, you put your lab analog, put it in the impression and send it like you would. Put a gingiva former, don't tighten it all the way. When it comes back, you put it in, and when you're tightening it, just hold the tooth and tighten, otherwise the whole implant will spin, right? Because the implant is just placed like yesterday. So just tighten the screw in such a way that it is not torqued but tightened, and leave it. Then you adjust the bite so that it's not in occlusion, and you have to check the exclusive movements, that it's not coming in the way. That's the most important. And of course, tell the patient don't bite anything, because if you bite, it's gone.
15 days to 1.5 months the implant is at its weakest. So if suppose the patient comes with a loosened
Don't do anything. Don't do anything. Healing abutment, then you can. Very lightly you can turn it and put it, but don't go and tighten it like aggressively.
then how soon we can reiterate? So if I place an implant, in my IOP here it is showing I'm going subcrustal, but in a follow-up scan I can just tighten 2 more
Then that day or the next you can.
next.
That day or the next, you can still do it. Even up to 72 hours you can still do it.
Sir, but sometimes because of bony obstruction, the healing abutment might get loosened after 15-20 days. So that time what to do?
Tighten it slowly. You can do it very lightly. Don't tighten it aggressively because the implant is going to be weak. So if you go and tighten it as though you're tightening it on a normal implant which is integrated, it will spin the implant because it is weak. There is still one level of mechanical stability still there. It's not completely loose. It's not hanging loose, but it's going through changes. So all you have to do is slowly, delicately tighten it till you feel that you can see. Everyone understands when a gingiva former is in final position. You understand. You can feel it, right? Tactile, you can feel it. So that only thing is you have to do it very delicately. Don't try and unscrew it. At the most, try and tighten it. That's it. See, anything that you do extra, like, oh, ye gingiva former chota hai, main bada laga tum, all that you don't do. Understand? Don't be heroic.
So unscrewing should be avoided.
Always. No, it's the same. It's the exact opposite movement to what you want.
So if we customize the abutment, then do we use regular abutment processes or do we use pre-milled abutment?
Not pre-milled. Why would you need pre-milled? Regular temporary abutment.
Not for final result.
You can use a pre-milled.
We can use regular as well.
You can use a regular as well, but a regular abutment will not.
Have a
Yeah.
we use
The contour they can recreate in the crown as well, but a pre-milled makes it easier. See, now I have moved away from the regular abutments anyway. Because it's always been a problem, this thing of food getting stuck. The regular abutments are too thin. A customized abutment will always give you width, right? So a lot of people now have moved away from that and are moving towards customized abutment. You charge the patient extra for it and tell the lab to reduce the charges.
Also, one more thing. So you said after extraction we use dye and through laser therapy. Can you tell the process?
So there is a technique by another company called Helbo. There's only one company which does it. Okay, it is a technique in which they have a system in which you inject a dye, it stains all the areas which are biologic, like which is soft, and then you use a laser to clean it. Okay, now that is one company which has that technique. It's not a standard technique, and it's a big investment as well. So you have to decide whether it's worth it or not, or something which you can clean physically. There are some people who are very fastidious about it. They may have the technology, but it's not standard. It's not. If that much money you can spend on something else, that is my point. You would rather buy a piezo surgery unit in that cost. When you have all of them and you don't know what to do with that extra lakhs of rupees that you have, you can buy it. I'm serious. See, there are clinics which are buying stuff from implant companies for 20 years, from different companies. So at the end of 20 years, you have everything else. Okay? Then why not spend a little more on refining your technique? So it's just an additional bit of help.